We start in 25 minutes. And welcome, everybody. This is the conference in a couple hours in noontime, Eastern time, which is about 5 hours. It's in French, and as most conferences are, they're partially in English. So stick around after Juha's talk. A couple hours after, actually. Conference in a couple hours in noontime, Eastern time, which is about 5 hours. In French, and as most conferences are, they're partially in English. So stick around after Juha's talk. A couple hours after, actually. A couple hours in noontime, Eastern time, which is about 5 hours. In French, most conferences are, they're partially in English. After Juha's talk. There's Abby. Abby, are you there? Oh man, that's cloudy. Yeah, show my camera. There's Abby. Not on that camera. Oh man, that's cloudy. On my camera. How are you doing, Juha?
Hello, John. Hello, Atul. How are we doing? We are doing well here.
Juha, how are you, Dr. John?
Hello,
Good morning.
Juha.
Good morning, Omar.
Hello.
Good morning, good evening, Dr. Atul.
Hello, how are you? John, what is the news from you?
The king arrives.
The king of John.
The king of Zoom. So what have you been doing lately? You doing every almost every night, right?
How are we doing? We are doing well here. Subin is today busy, so
Okay.
he cannot attend. So the Yan Lao, Yun
Yes.
Lao, yeah,
Yes.
is here, so he will translate. Hello, Ati.
Yeah, I saw him. Hello, Yin. How you doing? I saw him come in.
I saw his name. Yeah,
Yeah, I saw
he's
him.
translating, and
Yeah, make
Takeshi
sure.
is not here.
Oh, yeah. Oh, Dr. Mastronardi's here. Luciano. Yajin Liao. Dr. Liao, are you there?
Yeah, I'm here. Hello,
Now it's-
everyone. Yeah, I'm here.
Yeah, is your camera working okay?
Yes, yes, yes. Hello.
Well, let me get off there.
Hello, Liao.
Hello, everyone.
Hey, Eugene, could you do me a favor and put your email in the chat box if you don't mind?
You said
Okay.
me?
Yeah, you know the chat box for
Okay.
It's kind of private that way. How you doing? There you go. Thank you.
How is India? India has in flames, according to COVID.
India is in flames. Really, it is very, very, it is now gone in the rural India, rural. And also many young people are getting infected. And also there are two types. Either they are okay or either they die. So middle type people are not there. So
Oh
there
my
are
goodness.
many. So, young people suddenly dying is becoming too much, too much. It is a absolute.
How is
danger.
your hospital running? What are you doing in this situation?
Now we are doing just emergencies and a little bit here and there. We have, the whole city is locked down and patients are not able to come. There, whoever comes, we operate. So we operate just 1 or 2 or 3 a day, not many. China is, how is China? Okay, no problem.
China had yesterday 9 cases.
Wow, that's incredible.
9 cases.
That's totally incredible. So, Atul, it's worsening, you would say?
Yeah, it is. No, it is. I think last last few days, the things have plateaued a little bit.
Okay.
They have stabilized,
Stabilizing. Okay.
but they have not yet, out of hand. They are out
Okay.
of hand, actually.
Yeah.
Officially, there are 350,000 new infections a day
That's
around.
right.
Yeah.
That's right.
Wow.
Official
Wow.
and unofficial, maybe 2 times more.
Mm.
Wow.
No, it is too bad, too bad. And you talk to anybody, he's down with COVID. You talk to your friends, he's down with COVID. You talk to some of your relatives, half the family is down with COVID. And COVID is such a bad disease. You have it and you cannot breathe, you cannot talk, you cannot, your lungs are loaded. You need oxygen, your whole body is paining. You have fever, you cannot eat, your appetite is gone, you have loose motions. Means whoever I talk to, they are in such miserable condition. Even if they recover, they have suffered quite a bit.
Terrible.
And Florida, how is Florida now?
It's stable. It's getting better. The loosening up restrictions. Vaccines are everywhere. Everywhere you go. So things are getting better. Some states are not doing so well. California, Arizona, but it's not getting much worse, like India's. Okay, we got 5 minutes. Good morning, Takashi.
Yeah, good evening, everybody. Good evening.
Good evening. Good evening.
Yeah, Dr. Yuha, Dr. Guerson, thank you. Good evening.
Good evening.
Yeah,
Good
today I
evening,
was at
Professor.
Japanese Congress of Neurological Surgery in Yokohama. I just came back.
Oh, good.
Yeah.
Good. How good meeting?
Yeah, but due to COVID-19, so most of them are not attended only by website. There are only 50 or 100 people
Okay.
in Yokohama. Yeah.
How many neurosurgeons are in Japan?
In Japan, certified neurosurgeon is 6,000 to 8,000 these days. But
okay.
some of them are not working. So certified neurosurgeon system is reconsidered these days because too many neurosurgeons, certified neurosurgeons in Japan. So some of them are not working and not doing surgery, only doing clinics. But they are all certified neurosurgeons.
Yeah, I'd like you to meet Jahun Liao. He's your counterpart in China. You're physically, where are you at, Jahun? Are you in Shanghai? You gotta unmute there.
Me, you mean me? Hi,
Yes,
John.
are you in
Yeah, I'm
Shanghai?
Shanghai.
Oh, okay. And this is Takashi is translating in Japanese.
Yeah, Japanese.
He's
Thank
in
you.
Tokyo.
Nice to meet you.
Nice to meet you.
He's also a neurosurgeon. And there's somebody's got birds in the background. Here's Victor.
Hello, Dr. Juha, Dr. Atul. Hello, everybody.
Hello.
Hello,
Good evening.
Victor. Hello, Mexico.
Very,
How's-
very good. We are doing good. Very good.
Oh, things have stabilized with the COVID.
It's going down little by little, but
Okay.
we are much better than in the January, February. On this year, we are now very much better.
Good.
That's good. Good.
Okay. Okay, you ready to start, Juha?
And we are ready to start, yeah.
Okay,
I'm
okay,
ready.
okay, might as well start. Okay, a
One
minute
or two
early.
minutes.
Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett televising for Neurosurgical TV. Today we have another Juha's China Neurosurgery Grand Rounds, and we are graced again with the presence of who we fondly call a king of Zoom, Atul Goel. He's going to talk about versatility of the supracerebellar infratentorial approach. And I'll let Juha introduce him. Welcome, Juha.
Thank you. Dear colleagues, we have again great honor to have our friend, Professor Atul Goel from Mumbai here to talk. He's the chairman of King Edward's Hospital. And Atul Goel is certainly one of the most important neurosurgeons of these times in the world. So I have presented this question many times, how to become a good neurosurgeon. I never met in 50 years a person who wanted to be a bad neurosurgeon. But to become a good or even excellent neurosurgeon, you need heroes, mentors, and friends. You cannot become alone a neurosurgeon, and this is extremely important. You have to be a social person to be able to manage with other people and train hard. And this is the way Professor Atul Goel is doing. Extremely hard-working man. I have learned through 20 years so much from him, and especially now in these few webinars he has given. We had extremely good webinars. Follow his passionate lecturing. This is one of the role models in good lecturing. This is very extremely important. If you can do good neurosurgery, it's not enough. You remain a local hero. You have to publish, and you have to be present your skills in appropriate way. So neurosurgery has three parts. Operative skills, of course, the most important, but then you should do research, clinical in the case, operating neurosurgeons. You can do also basic neurosurgery, the basic science, but this might not be so well appropriate for clinical neurosurgeon. And then you have to do teaching. Atul, like John mentioned, is the king of webinars. He's passionate giving lectures, webinars around the world. And this is extremely important to carry out the skills and knowledge to others and younger generations especially. So how to improve all the time? So you should analyze your own experience, and publishing makes you 5 times better surgeon. There's a lot of talk about paper tigers. Paper tigers cannot operate on, they just publish and give beautiful lectures, but this is not true. It can be everything like we will see by Professor Atul Goel. You should not believe everything what has been done and what is widespread in treating our neurosurgical diseases. You should think. My teacher in 70s in Helsinki, world famous stereotactic neurosurgeon Lauri Laitinen, he told that neurosurgeon should think at least 1 day a week. And this is maybe a good advice. I didn't follow it always. But you should think what you are doing, and you should observe your patients and surgeries. This is very important. And you should learn from others. You should have open mind. We should develop all the time. And when we see something good, then we should try and take in our armamentarium. This is the World Neurosurgery 2014. World Neurosurgery selected 69 most important neurosurgeons in the world during the last 100 years, beginning by Cushing, Dandy, Yasakil, of course. And then we see here is Atul Goel from Mumbai, India. So these are extremely important persons to influence to influence the world. Professor Atul Goel is operating, let's say, hectically 1,500 personal operations a year. You can ask how to do it. You have to be excellent neurosurgeon, of course, but you have to organize your clinics and you have to be surrounded by good supporting team and the patients and society. Without society support, you cannot continue. And of course, you have to, for this big number of patients, you have to have big population. This is how I think about neurosurgery. You should train your best young people. My teacher, late Professor Charlie Drake, was saying this way that we have to find for training someone who is certainly getting better. If we don't find, then we wait. So these youngsters, they should become better than we, and this is extremely important. You should support the young generation because in this way you will also get by far stronger. If you prevent them to grow up, then you are not doing well. So I give the word to Professor Atul Goel. Thank you, Sei. Kiitos. Professor Atul Goel will speak about the supracerebellar infratemporal approach. I have used this approach a lot, but I give now the word to Professor Atul Goel, and we can come with different discussions back to that. So please go ahead, Atul.
Thank you, Juha. Needless to say, I'm extremely proud and honored to be on this very important Juha symposium. And I thank John for giving me some nice titles. And needless to say, I am very proud to have that title, John, King of Webinars. That is a good title, and thank you very much, John. That is more of your love and affection than anything else.
You do a lot.
So today I am going to talk on a special approach, lateral supracerebellar approach. And as you know, this approach is gradually but surely becoming a very important neurosurgical approach. And I'm going to discuss with you how we develop this approach and how we use this approach. It has some special features. When you use any neurosurgical approach, it should be easy to do. You should be able to remove the entire tumor completely from one approach. You should not say that I will remove half tumor here and half tumor I will remove by some other approach. The entire tumor should be able to remove by one single approach. That is very important. You should be able to quickly reach the target, and you should have the entire field under your complete control. There should not be anything which is left out of control. So I think supracerebellar approach is a unique approach, and it is quite useful for several indications. So this is the cover page of my book, which we wrote in 1996. When we become skull-based surgeons, we learn how to do middle fossa approach. We learn the anatomy of the petrous apex. And as you develop learning and understanding that anatomy, you develop various surgical approaches from middle fossa. So in 1996, you can see the cover page of my book, where the petrous carotid artery has been displaced. The facial nerve has been displaced. Gastrian ganglion has been moved up, and the entire petrous bone has been removed. So this is a kind of exposure that looks very straightforward, but it is quite a complex exposure. You need to understand tremendously the subtleties of anatomy of each and everything that you see here. There will be venous bleeding, there can be arterial bleeding, and there can be various things that can happen. So this was my, very favorite surgical avenue, the middle fossa approach. If you see the skull bone, there are various holes in the skull base. This is the sella. These are the various holes in the skull base from various arteries and nerves exit and enter. And this is the clivus. This is the petrous bone, and this is the internal artery meatus. These are the very favorite anterior clinoid process. These are the posterior clinoid processes. The cavernous sinus is in this area. So as we learn skull base, as we mature in our understanding of skull base, and we become skull base surgeons, this anatomy is ingrained into our system. And you see the beautiful anatomical work of Roton. Here is the gastrian ganglion, V1 division, V2 division, V3 division. These V1 and V2 divisions forms the lateral wall of the cavernous sinus. This is the third cranial nerve, and this is the tentorial edge. In the tentorial edge, the fourth nerve comes, and then it enters along with the third nerve into the lateral, superolateral corner of the cavernous sinus. This is the petrous carotid artery, and this is the greater superficial petrosal nerve, and this is the middle meningeal artery. So as you can imagine, petrous apex is quite a busy area, quite a congested area, and you have to know very clearly the anatomy of the GSPN or greater superficial petrosal nerve, the carotid artery, the Kawase triangle, the gastrian ganglion, foramen ovale, foramen rotundum, and various other things. So we are taught very heavily about the middle fossa and petrous apex anatomy. This is another very beautiful slide that I want to rapidly show you. This is the fifth nerve which has been moved laterally. This is the V1 division, V2 division, foramen rotundum. This is the region of cavernous sinus. The third nerve has been elevated up. This is the fourth nerve. This is the sixth nerve which is coming lateral to the petrous carotid artery. And here is the entry of the petrous carotid artery into the cavernous sinus. This is the meningohypophyseal trunk. And these branches, these nerves, which come along with the carotid artery, quite a number of nerves. These are the sympathetic nerves. And they are very important nerves of the cavernous sinus. So petrous apex, cavernous sinus anatomy, whoever is doing complex neurosurgical work has to clearly understand. Clearly, there should be no ambiguity in this understanding. So cavernous sinus is located by the side of the pituitary gland, medial to the temporal brain, lateral and superior to the sphenoid and paranasal air sinuses, and is quite a beautiful structure. So of course, today I'm not going to talk too much about cavernous sinus and pituitary tumors, which we have already discussed earlier. So this is the petrous bone. This is the clivus. This is the region of cavernous sinus. This is the region of sella. This petrous bone or petrous pyramid goes like that. And this is the external ear canal. You draw a line like this, external ear canal, you go straight to the petrous apex. Here is the eustachian tube. This is the middle ear, and this is the labyrinth. So petrous anatomy, external carotid artery, internal carotid artery, petrous apex, eustachian tube, all these things have to be very importantly understood. So petrous apex is here. If you make a straight line, petrous apex is quite close to the temporal squamous bone here in this direction. On the other hand, from the retrosigmoid or supracerebellar approach, petrous apex looks a little bit far away. So as we know, in my own journey, I have worked very elaborately on middle fossa approaches, and this is the approach that we had described long time ago. In 1996, we had published this article where we removed the root of the zygoma, roof of the condyle, roof of the external ear canal, and included mastoidectomy in the subtemporal craniotomy. So subtemporal craniotomy with mastoidectomy was first described in this article. So when we include mastoidectomy and we go closer to the petrous apex, we remove the mastoid antrum and then labyrinth and accordingly whatever we need. So this is a middle fossa, extended middle fossa approach that I used quite extensively earlier. And you can have extradural exposure or intradural exposure by middle fossa route. For trigeminal neurinomas, as I have discussed, extradural, interdural approach is a beautiful approach. For petroclival meningioma, of course, we have to do an intradural approach. Extradural may not work for petroclival meningiomas. You can take a tentorial dural incision that we described in 1995, something similar to what Drake used to do for basilar tip aneurysms. Then we reduced our exposure, minimized our exposure. We rotated the temporalis anteriorly, split the temporalis muscle, and various things we did to minimize the middle cranial fossa approach. Our understanding of dural anatomy. So we introduced extradural approach by middle fossa route for intracavernous sinus tumors, like cavernous hemangiomas of cavernous sinus, pituitary tumors, and various other things, extradural route. We talked about interdural route. So when the tumor is in the petrous apex and middle fossa and goes in the posterior cranial fossa, but we know that it is trigeminal neurinoma, my standard surgical access is through middle fossa approach, work interdural, and you remove this tumor. So for such tumors, which are petroclival and cavernous sinus, but they are not meningiomas, they are trigeminal neurinomas. So these tumors, my preferred route is interdural route. And even such tumors like petroclival tumors or petrous tumors which go in the infratemporal fossa, facial neurinomas, my access route is subtemporal, interdural, middle fossa route. So middle fossa route is the very important route for a skull-based surgeon. So this was my middle fossa middle fossa basal extension, which I used to do for petroclival meningiomas. And I still do. For a lot of petroclival meningiomas, middle fossa approach is beautiful route. So this is the tumor that we did in 1993 or 94 by middle fossa route. I didn't know any other route at that time, and extensive exposures, and this patient is still alive and quite okay. So, and this was another beautiful tumor that we removed by middle fossa route. One thing I will let you know is tumors which go from one compartment of dura to another compartment of dura, like they are outside the cavernous sinus, inside the cavernous sinus, and some tumors which go into the paranasal sinuses are inherently more aggressive in their nature. So we removed this tumor and there was recurrence in this part of the tumor. And when there is tumor which goes like this in various compartments, there you have to consider radiation treatment if you have not removed the tumor completely. And some other tumors which I will rapidly show, which we did long time ago by middle fossa surgical route, and we have spent a lifetime in these middle fossa surgical approaches. So this is another tumor which I had shown earlier. So this tumor, which is having both internal carotid, basilar artery, PCOM artery encased, and I did this in 1994, 95. And this patient is also alive, where you can see my extensive exposure, both middle fossa, posterior cranial fossa, and this tumor was radically removed. And there's no question that middle fossa approaches form the bottom line of a skull-based surgeon. This is posterior clinoid meningioma. One can imagine that there is no other surgical route other than transperineal or basal subtemporal route to remove this tumor. So middle fossa route. Now the question comes of tumor which goes in the posterior fossa like this. So when there is larger component of the tumor in the middle fossa surgical route is the preferred route. And I will like to do basal, extended, subtemporal, basal approach to remove this tumor. So this will be my avenue for removal without any doubt. However, when the tumor has a major component in the posterior cranial fossa and a relatively small component in the middle fossa, I am questioning the need for middle fossa approaches in these cases. And this is the subject of my discussion today. Tumors like major component in the posterior cranial fossa and little bit in the middle cranial fossa, what will be the best surgical approach for these tumors? That is the question I am going to discuss. This is another tumor having some middle fossa component in the cavernous sinus and a large posterior cranial fossa component here. Basically, this patient will come with symptoms of ataxia and brainstem involvement. Your main thirst of surgical resection is this component, and whether you can and whether you should remove the cavernous sinus portion is a questionable thing. This is another tumor which I had done long time ago by a middle fossa route, and I had some difficulty in accessing this lower cranial, this lower clival portion of the tumor. So this was removed quite radically, but some tumor was left behind because my access by middle fossa was not enough. Such tumors which have a large vascularity in the middle fossa part of the petrous apex component of the tumor, there is no question that you have to do a middle fossa approach to remove this tumor, which was removed like this. This is another tumor with significant attachment and origin in the region of the middle fossa. To access this component from the posterior fossa will be difficult. So this tumor also, I will recommend a middle cranial fossa route. Because of my passion and fascination for middle cranial fossa, even this small tumor, which today I will remove by a supracerebellar approach, I removed by a middle fossa route. You can see here, and I approached this tumor by a middle fossa surgical route. Tumors like trigeminal neuronoma is different, but meningiomas which go in the cavernous sinus with this kind of extensive involvement, middle fossa surgical route is a preferred surgical route, and this is the post-operative image. This tumor also in the cavernous sinus and in the posterior petrous apex was removed by a middle fossa route using the anatomy of the petrous apex, carotid artery, facial nerve, and things like that. and you can give a brand new life to these people. This is another tumor where middle fossa root was adopted long time ago. All these cases which I'm showing you are done at least 20 or 25 years ago. So this is another tumor which was removed by middle fossa root and radical resection of this tumor, including the part in the cavernous sinus. So that is the surgical strategy for this. Trigeminal neurinoma, also basal subtemporal root. Then I started, as I developed middle fossa root, for the first time in literature, we describe mobilization of the facial nerve like this, just tympanic and labyrinthine segment of the facial nerve, not the mastoid segment. So these two segments by middle fossa root, we discussed, and we did a lot of tumors by middle fossa root by extensive exposures. So extensivity of the exposure, mobilization of the carotid artery, which is not easy. Mobilization of the facial nerve, which is not easy. Mobilization of nerves of trigeminal nerve, gastrin ganglion is not easy, but these are required for petrous apex tumor. So this tumor, which I will now do by a supracerebellar approach, was operated by me by an extensive exposure by a middle fossa root. You can see this is immediate postoperative scan, and this was removed by a very extensive exposure, which I think today may not be necessary. This is another tumor which I had removed by mobilization of the facial nerve, by transpetrous root, extensive drilling of the petrous bone, extensive. But today, if you ask me, I will like to do this operation by a supracerebellar operative route. So this is another tumor which we removed by very extensive exposure of the middle fossa. So now my thing is, my aim of my presentation is to show you the versatility of supracerebellar approach. You see in this lateral supracerebellar approach, this for petroclipal meningioma was described first, for the first time in the literature in this article of mine. Of course, Sami had described retrosigmoid approach like acoustic tumor, retract the cerebellum and do the tumor resection like acoustic tumor, and to remove the petrous apex and all those things he described. But this paper discusses the supracerebellar approach, and if you realize, this approach has become a very popular approach for people who are doing petroclipal meningioma. So this is in that paper. So retract the cerebellum down and expose the petrous apex. Let me go through the journey of supracerebellar root. Now, when the tumor, this is of course not exactly a petroclipal meningioma, this is a petrous meningioma. There is no question in anybody's mind that retrosigmoid operation is a beautiful operation for this, to come transpetrous and deal with facial nerve and all those. And more important is superior petrosal sinus is also a troublesome entity here. So there is no need for transpetrosal approach, but I will say that many people in the world still do transpetrosal approach for such tumors, but there is no way. You just do a smallish craniotomy here, posterior fossa, retract the cerebellum and do a good dissection and tumor resection. This is another tumor with a large attachment to the petrous bone, and retrosigmoid is a beautiful operation for this. There is no question about it. To come transpetrous and do petrosectomy and do all those kind of things is not a good option according to me, and retrosigmoid is a beautiful option, and many or most of the surgeons in the world will adopt this strategy. Now tumors which are more anterior, like petroclipal, little bit petroclipal. Now the controversy is whether you will like to come in this direction, remove the petrous apex and all those things. But I can tell you, after my about 35 to 40 year experience in skull-base surgery, there is no way I will do it by transpetrosal approach or middle fossa approach. This is a beautiful approach, supracerebellar approach to remove this tumor. Supracerebellar. When you do supracerebellar, You retract the cerebellum down and start debulking the tumor. The fifth nerve, which is laterally displaced, is beyond. The seventh, eighth nerve is also not in picture. You come like this, remove this tumor, and how you demolish the tumor, how you remove the tumor will then depend on your skills of understanding of tumor resection. So, sorry for that.
Okay.
So this is a clear case for supracerebellar infratentorial lateral approach, and you can beautifully remove this tumor. Tumors like this, large tumors, are very difficult to remove by middle fossa approach. On the other hand, supracerebellar approach, you come, you start debulking the tumor. Most important in tumor surgery, most important understanding in tumor surgery is how you debulk the tumor, how you demolish the tumor, what you coagulate, what you don't coagulate. There is hardly any need to coagulate. You can remove this tumor in very quick time. I will say this tumor, I don't remember, but because this is a very old case of mine, but this tumor should not take more than 45 minutes to be removed. Debulk the tumor, then dissect the surrounding structure. No need to do any kind of petrosectomy or petrous bones. So this is a clear-cut case for supracerebellar surgical route. Similarly, tumors which are involving like this, I will prefer a retrosigmoid and supracerebellar approach to remove this tumor, because you retract the cerebellum, you get to the tumor, and then you debulk the tumor. Tumors like this, which are more anterior, like this. Over the years, my experience of supracerebellar route, I remove this tumor by supracerebellar, retract the cerebellum down, debulk the tumor, debulk the tumor, debulk the tumor. Most important thing which I can tell you is about supracerebellar route is that you get to the sixth nerve early in the operation, and sixth nerve is in the most danger in this operation. If you come from the middle fossa route, the sixth nerve comes quite late in your exposure, and you can actually damage the sixth nerve. You can damage the sixth nerve by any surgical route, but sixth nerve and dissection becomes much better if you are doing supracerebellar surgical route and you see complete beautiful resection. This is another tumor which I used to do by middle fossa route and facial nerve mobilization and Kawasai's triangle and all these cavernous, sinus and trigeminal nerve. But now for several years, retrosigmoid supracerebellar infratentorial approach is a beautiful approach to remove this tumor. I will show you some videos very soon. You just see what kind of tumors I will like to do by this approach. So this is another tumor which is almost a petroclival tumor. I will like to do it by supracerebellar surgical route, and this is the post-operative image. This is another tumor which several neurosurgeons in the world will like to do by middle fossa route or by any other route, but this approach is also a beautiful supracerebellar route. Know the tumor, debulk the tumor. There are several dangers when you are doing supracerebellar route. One is the PCOM artery can come in severe danger. And of course, the third nerve can come in danger, and basilar artery, and various things can come under danger. There is no question in my mind that this is a classical case for supracerebellar combined with retrosigmoid approach. You identify the facial nerves, easily dissect, and if you ask me about the grading of this tumor, I will say it is quite a straightforward, simple surgical approach. So this is the beauty of the cerebellum dissected by one of my residents, and you see the cerebellum, and there is one very important petrosal vein, superior petrosal vein. This is the petrosal vein which goes as you retract the cerebellum down. This is one vein which comes in the picture. And there are several articles written whether you can take this vein or you cannot take this vein. There can be a danger if you of infarct when you do trigeminal neuralgia, for instance. But for petroclipal meningiomas and for supracerebellar root, this vein should be taken very early in your operation. And only then it is possible to retract the cerebellum down. Otherwise, you cannot retract the cerebellum down unless you take that. And once you take the vein and you retract the cerebellum, you can see this is the normal anatomy, of course, and you can see the beauty of this anatomy after you remove the tumor. So retraction of the cerebellum down, anteriorly, laterally, so there is a whole complete lateral surface of the cerebellum can be retracted down. Tumors which are going low down in the clivus, middle clivus or lower clivus, no question that there is no need for any kind of petrosectomy to remove this tumor. You do retrosigmoid operation, supracerebellar combined with retrosigmoid and remove this tumor. This is another tumor which is right in the petroclival area, which has been removed by retrosigmoid supracerebellar surgical route, and a beautiful. See, many of these tumors are soft tumors. Many of these tumors are not very vascular tumors. Many of these tumors have a beautiful plane of dissection. So if you retract the cerebellum, in 1 minute, you can come to the tumor. And then you work on the tumor, you dissect the tumor, you resect the tumor. Even the part of the tumor which goes in the cavernous sinus like this can be removed by a supracerebellar route. Of course, to remove this part of the tumor can sometimes become difficult, and you have to drill the petrous apex in some occasions. And sometimes to get the exposure of the cavernous sinus is not straightforward. So this part of the tumor can be more difficult to remove by a retrosigmoid operation. Tumors which go above the tentorium like this. You see, this is the petroclival tumor, and this tumor has gone above the tentorium. It is possible to remove even this part of the tumor without any issue. You cut the tentorium, you save the fourth nerve. Fourth nerve saving tumor, which is removed by retrosigmoid operation, retrosigmoid supracerebellar route. And if you ask me today, I will not even attempt to do any middle fossa surgery for this, which I was using earlier in my career quite extensively. This is a clear case for supracerebellar approach and demolish the tumor, learn the art of breaking the tumor, demolish the tumor, and then save the work in the subarachnoid plane to remove the tumor. This is another tumor which has been removed by supracerebellar route, and there is no petrosectomy, and in very quick time. So this is another tumor. You see quite a tumor which I have removed by supracerebellar route. There is some tumor residue in this part of cavernous sinus and little bit over the clivus, which was missed. And whether to give any radiation or not for this is a questionable thing, but you see this tumor has been beautifully resected. Now these tumors which have blood supply from the posterior face of the petrous bone can also be removed by supracerebellar route and can also be removed by middle fossa route, but I prefer supracerebellar route to remove this tumor, and this is the postoperative image. And you can now clearly understand for tumors like this, there is no way I will do any other approach other than retrosigmoid. See, I will tell you that many people in the world still do middle fossa route for these tumors and all, but this tumor has also been removed by retrosigmoid operation in a very beautiful supracerebellar tumor supply from the meningohypophyseal trunk has been handled. So this is another tumor you can see by a supracerebellar surgical route. Now tumors like this, which are going in the cavernous sinus, you can see from the face of the tumor that it is quite a soft tumor. You retract the cerebellum down and you debulk the tumor, And then at the end, you can follow the trigeminal nerve into the cavernous sinus. And believe me, this tumor, you can remove in quite a quick time, maybe not half an hour or 45 minutes. That kind of timeline for petroclival meningioma, usually when you see petroclival, this is of course quite a soft tumor, and this has been removed, and even the part in the cavernous sinus has been beautifully resected. Now, tumors which encase the basilar artery, vertebral artery, it is very difficult to come from the middle fossa surgical route. And this is post-operative scan. Let me show you the terminal part of this operation. And you see this cranial nerve. This is the basilar artery. This is the trigeminal nerve. And this is the brainstem after removal. And you see this is supracerebellar and retrosigmoid operation combined. And you can remove, I will say, these are difficult problems as we know, but a beautiful resection is possible by supracerebellar surgical route. As I mentioned to you, PCOM artery is in quite a bit of danger if you are going to do supracerebellar surgery. So this artery, if you damage, you can have a very serious deficit. And I will like to just show you a little bit here. I'm not sure what I'm going to show you. So first thing what I'm doing is I am cutting the petrosal vein. Once I cut the pit, you see I have retracted the cerebellum down. I'm cutting the petrosal vein, and then I'm going to, you see here this tumor is a little bit firmer tumor. I'm not sure if you can see it properly. The fifth nerve is displaced laterally. And once I get into the region of the tumor, then I have to break into the tumor. You see, this is the tumor which is beautifully seen, and within quick time you can remove this tumor. Maybe I will show you details of this case later. This is another tumor, basilar arteries encased and all those things which make it difficult. But you see, whenever basilar arteries encased, many of these tumors are soft tumors. So this was removed by supracerebellar surgical route. Let me show you some clips of this terminal part of this operation, supracerebellar. The entire thing is supracerebellar. What you have to do is learn the art of breaking the tumor. Fourth nerve is very important along the tentorium. Fifth nerve, you see at the end of the surgery, you can have such beautiful view of the entire field, which is, of course, the tumor was also not very firm in this case, and you can do a beautiful resection. This is another tumor. You see, earlier in my experience, I used to do middle fossa route for such tumors, but I can very confidently tell you that there is no way I will do middle fossa surgical route for such tumors. So you see, this is the basilar artery. This is the trigeminal nerve, which I am moving with my suction. And I can see the vertebral artery, and you see how much extensive my exposure by supracerebellar. And most important is that the sixth nerve can be dissected, can be identified early in the operation, and can be dissected of the tumor quite early in the operation. So this is another tumor and has been removed by supracerebellar surgical route. Some part of the tumor in the cavernous sinus could not be removed and has been left behind. I am not sure if I had done middle fossa route, I would have been able to reach low down in the clivus to remove this tumor. So supracerebellar is a beautiful approach for such tumors. This is another tumor by supracerebellar route. This is a vascular tumor. No way today I will do a middle fossa petrosal apex drilling or any other approach other than supracerebellar and retrosigmoid combined for such a tumor. Tumors which are in the clivus, of course, there is no way today I will do this operation without any doubt by a retrosigmoid combined with supracerebellar surgical route. This tumor, I think, was removed by very extensive petrosectomy long time ago. This is another tumor. This is a classical petroclival meningioma. You see some clips I'm going to show you. This is the petrous bone which is bleeding at the end of the operation, which you see this is the terminal part of the operation, not early part of the operation. What I want to show you is, you see this kind of coagulation at the site of attachment is done only at the terminal part of the operation. Otherwise, you see, you can have a very massive exposure of the whole field at the end of tumor resection. This is another tumor, and I would like to show you how much inferior you can go. You see, this is the basilar artery. By supracerebellar, you can have a very beautiful exposure of the entire basilar artery. See, you have to, most important thing, as I have mentioned to you, is the posterior communicating artery, which can come in the danger. You have to have the knack of handling the sixth nerve. You cannot damage any single perforator. And if you have damaged one perforator, you have indeed damaged the whole patient. And you can then, you see, you have the whole trigeminal nerve, which I am dissecting. I know it is a little bit tricky to show. Those who are experienced in this business of petrous apex surgery know exactly what and where I am. Now the question is leaving some tumor behind. You see, this sixth nerve patient comes with a sixth nerve problem. I could not dissect the sixth nerve, but I could see the sixth nerve completely in my surgical vision. So complete resection is not the aim of surgery. Preservation of function is a very critical part of the surgery. So this tumor also has been left behind quite significantly. I do not know why we have left behind, but possibly the dissection from the carotid, from the basilar artery was not possible, or some things were not clear during that part of the operation. This is another tumor which is encasing the basilar artery, and large part of the tumor was left behind. And this case was done by me in 1997 or 98, and this patient was completely all right till I met him few years ago. I don't know now what is happening to this patient. Now, question of leaving cavernous sinus tumor is a little bit of a tricky question. You should remove, and you have to remove, the part in the cavernous sinus, but by retrosigmoid and supracerebellar approach, this part resection becomes a little bit difficult. So this, I am just showing you, this was the pre-op and this was the post-op in 1997. And there was a radical resection. This tumor, petroclipal, recurred in 1999. I again removed this tumor, and again this recurred. So biology, tumor biology is the most important when we deal with tumors rather than your radicality of resection. You have to be very, you don't have to show your technical mastery or technical skills. What you have to show is your results. Your patient should be all right. This tumor, of course, will be removed by retrosigmoid combined with supracerebellar, if at all. I'm not sure whether supracerebellar may have been important. Now I want to take you to another tumor. I have given you my strategy of meningiomas. I have given you my strategy for petroclipal meningiomas. I will now talk briefly about chordomas. See, chordomas, we discussed long time ago that chordomas destroy the bone and displace the soft tissue. So they displace the carotid artery anteriorly, they displace the cavernous sinus superiorly, they displace the brainstem posteriorly. There is dura intact here. And going intradural of chordoma is an extremely rare clinical entity. I have actually seen very extremely rarely chordomas going intradural. So these tumors will devastate the bone and displace the soft tissue. They are located in the petroclival region. Now the question of removing carotid arteries displaced anteriorly. So lateral approaches are beautiful approaches, although nowadays we do transnasal and endoscopy and all those things. When the petrous carotid is displaced anteriorly, the cavernous sinus is displaced superiorly, the dura is displaced posteriorly. So you can work in this by a middle fossa route in a very effective manner. And we discussed middle fossa subgastrian ganglion approach to remove such tumors. When you see carotid artery displaced anteriorly, that is a chordoma. No other tumor will displace the carotid artery like this. And when you see this tumor, you should clearly understand that the dura is going to be present. And then you can remove this tumor. We had adopted middle fossa approach to remove this tumor at that time. This is another tumor, which is a chordoma, which was clearly a chordoma. This is postoperative image. Let me show you some little bit brief video of this by middle fossa root. I have to say that for chordoma, my preferred surgical approach for a tumor which is going laterally is middle fossa. So this is the carotid artery, and you can have carotid artery under your exposure. You can have the sixth nerve under your exposure, and you can work under vision. So middle fossa root is a beautiful root. Although many people are now talking about endonasal root. Endonasal root is good for selected cases, but middle fossa root has its own place in the treatment of chordomas. I want to show you supracerebellar approach to clival chordomas. Of course, there are very few indicators for supracerebellar root. So this patient I did by supracerebellar surgical route. You can see the tumor in the middle fossa and it has been removed. And this is my surgical access. This is immediate postoperative period. Retract the cerebellum, work. Most important thing for this, I'm not saying you should use this supracerebellar approach for clival chordomas. I'm not saying, but for this, the more important thing was the sixth nerve I identified early in the operation. And I must say that this approach is possible, but I'm not saying it is the best. Middle fossa is the best, and maybe endoscopic may be an option, but this tumor, which was going very much posteriorly, I did supracerebellar route to remove both the cavernous and the nasal area of this tumor. This is another chordoma. You see it is going in the clivus. This was clearly the chordoma, clival chordoma, quite in the posterior cranial fossa. I removed it by supracerebellar surgical route. This is another tumor which I removed by supracerebellar route. And you can see very radical tumor resection. I am not saying supracerebellar is the best, but I can say for sure that the sixth nerve controlled by a supracerebellar and retrosigmoid operation for such a huge tumor is the best. If you are coming by the nose, you see the sixth nerve much later in the operation. You're coming lateral, you have various issues, but lateral is the probably a good operation. And I have done all my cases lateral, except for the ones which I'm showing you and which I published. So supracerebellar approach for clival chordoma is an option. Now I'm showing you epidermoid tumors. Epidermoid tumors, my experience is without any question largest in the world. So in 2006, I published 24 cases of pineal epidermoid tumors, and I published in 2006 96 cases of tentorium-based epidermoid. Now my experience with tentorium-based epidermoid is quite huge, which I am going to publish very soon. See, these are the epidermoid tumors, and these tumors are special tumors. And you have to remove these tumors in a special way. They are beautiful tumors, all right, but they go in various compartments, and I label them as tentorium-based epidermoid tumors. These tumors are not in the cerebellopontine angle or any other angle. They have been labeled as CP angle epidermoids. But I prefer to call them tentorium-based epidermoid tumors because they are located in the region of ambient system. They go above the tentorium. They go in the CP angle, cerebellopontine angle, cerebellomedullary angle, cerebellomidbrain angle. So they are quite extensive, and to call such tumors as CP angle epidermoids is not good. Moreover, if you know that they are tentorium based, a supracerebellar approach is the most beautiful approach to remove these tumors, which we discussed for the first time in the literature, this kind of supracerebellar approach for epidermoid tumors. So for epidermoid tumors, my strategy is first is lateral supracerebellar route. Then I cut the tentorium and I remove the supratentorial component of the tumor. And the third stage is resection of the part in proximity to the 7th, 8th, and lower cranial nerves. So I have got a very huge experience with epidermoid tumors. You can see this is one of these cases. This is going inside. You see the relationship with the brainstem, relationship with the fourth ventricle. Then this tumor goes in the region of the suprasellar area, in the region of the pituitary gland, in the region of the chiasma, in the region of middle fossa, above the tentorium. So it is quite a huge, extension of these tumors is very big before they become symptomatic. So that is the beauty of these tumors. They go in the middle fossa, they go across the midline, they encase the basilar artery, they go in the suprasellar area. So for epidermoid tumors, supracerebellar approach is the most beautiful surgical approach without any question. And this is we described about 25 years ago, this approach for these tumors. There is retrosigmoid is not a good operation. You come first in the supracerebellar, remove this tumor, and then once the whole system has stabilized, you can remove this kind of extension by supracerebellar surgical route. So these are the tumors and this is the resection. So going in the middle fossa, you have to do a supracerebellar and a quick operation and a very controlled operation. I want to show you some initial steps in this case, and then I want to show you a case of a very large epidermoid tumor. So first is retract the cerebellum. These are very essential steps of supracerebellar route. Open the cisterna magna and release the CSF from the cisterna magna. This is very important first step. Then retract. You see how the cerebellum is lax. Of course, it will not be so much lax in Petroclipal Meningiomas, but it is not very tight as well, like acoustic tumor. Then you go supracerebellar, identify the tumor. And there is a special trick to remove these tumors, special art of breaking the tumor, which you have to learn. Epidermoid tumors have a, and you see in exactly 5 minutes, you can reach the tumor and start breaking into the tumor. I will show you few steps and then I'm going to show you another case where I'm showing you all the tricks of removing an epidermoid tumor by this route. What you have to do is you have to tease the tumor, break the tumor, tease the tumor, and you must remember that these tumors, the patient comes with very few symptoms. You are not allowed to take any blood vessel and you are not allowed to take any cranial nerve. And if you have taken, it is going to be very, it is going to be very disastrous for the patient because the symptoms, presenting symptoms are very few. So supracerebellar, you come, start removing the tumor anterior to the brainstem, and then you take a tentorial incision. This is the tentorium. You take a tentorial incision. You see, I have removed only little bit tumor, and then I am opening the tentorium, and then I will work above the tentorium. So this is quite a straightforward surgical incision in the tentorium because you are doing when the tentorium is quite widely exposed, particularly in epidermoid tumor. In Petroclipal Meningiomas, maybe this is a little bit not so easy. So there is the tumor in the middle fossa. So supracerebellar, you see my access from the supracerebellar route, transtentorial route in the middle fossa part of the tumor. Here you will see the pituitary stalk. Here you can see the arteries and you can see the optic chiasma and various other things. Most important is it is a very quick operation, and to do any other approach for me will be may not be that easy. And if you come by middle fossa route, this part of exposure becomes very difficult to retract the temporal brain, and to remove this tumor becomes a little bit tricky. Then you have to open the sylvian fissure widely, and then you have difficulty in removing of the infratentorial compartment. So you see this approach is quite a beautiful approach for all components of the tumor. Supracerebellar approach. Now, how to remove epidermoid, how to remove the capsule of the tumor, whether the capsule of the tumor should be removed. You see, I am removing this tumor by gentle suction, which is a controlled suction. And you see very other few instruments are coming into picture. This kind of suction has to be learned and has to be very appropriately learned if you have to remove this tumor. As I mentioned to you, I change my hands for various kinds of suction, various kinds of tumor. For vascular tumors, my suction is in the right hand, and for aneurysm, my suction is in the left hand. So now I want to show you this tumor. You see, this is a mega tumor going in the middle fossa, in the region of the pituitary gland and things like that. And I want to show you a little bit larger video of this. So this is the transverse sinus. This is the flaps of the dura I have taken. Then I release the CSF from the cisterna magna. And you see some tumor is there in the vicinity of the lower cranial nerves. I will not remove the tumor in the vicinity of the lower cranial nerves at this point of time. First, my approach is supracerebellar and removal of the part of the tumor anterior to the brainstem. Supracerebellar. The fifth nerve is in very close proximity to these tumors, fifth nerve. And you see the fifth nerve is already coming in picture, which is laterally displaced by this tumor. Now you see here, Lucky. Fifth nerve and the tumor. Then I am removing this petrosal vein comes in picture, which I will coagulate and I will cut. You see, this is the only thing I will coagulate in the entire operation, because any other thing I coagulate will be absolutely, in an epidermoid tumor, you are not allowed to coagulate anything. If you coagulate, you have probably created a disaster. Now you see the fifth nerve is displaced laterally by the tumor, and learn the art of breaking the tumor. Learn the art of breaking the tumor. Epidermoid tumors are very beautiful tumors. You know, I'm just trying to show you the exposure, kind of exposure that you can get. This kind of exposure is not possible in meningioma so easily. See, I'm sucking into the tumor and breaking the tumor. Epidermoids are, of course, relatively straightforward tumors to operate. So, but if I have to show you the anatomy, this is the best tumor to show you the anatomy. We have to save the fourth nerve, very important, along the tentorium. And of course, we have to save the sixth nerve. Sixth nerve is in quite a danger in epidermoid tumors of this kind. And you have to save the sixth nerve. And I have to tell you that this tape is also not very heavily edited. Then I am going over the fifth nerve and over the and you can see the supracerebellar surgical avenue. And now I am going along, I have to save the, along the tentorium, I have to save the fourth nerve for sure. Then I am going, you see here, I have not shown, but I have probably cut the tentorium earlier. And I am going in the supratentorial compartment of the tumor. And you can see the whole thing, I am working in the supracerebellar surgical route. So essentially, supracerebellar surgical route can be done as an initial strategy for petroclipal meningiomas, for brainstem tumors, and for epidermoids without any question. Without any question. For epidermoid, this is the surgical route, which we described about 25 years ago. Now, what you saw inside was the third nerve. And you will see the anatomy very clearly in this case. See, break the tumor. You see how this tumor don't have to use sharp instruments and things like that. You have to just break the tumor, break the tumor. And, and you see my handedness. I am holding my suction in my right hand and gradually making space for myself and removing the tumor. And if you ask me today, this is the fourth now, if you ask me what is the approach for epidermoid tumors, there is no question that supracerebellar approach is the surgical approach for epidermoid tumors. And those who are doing epidermoid tumors, if you try any other approach, you may land into quite a serious problem. Because retrosigmoid approach is not a good approach for this, because all the cranial nerves are displaced laterally. How to remove this tumor, how to break this tumor, one has to learn very elaborately. Now here I will probably see, you see here is the tentorium has been cut. I'm looking in the middle fossa. And this is the tumor in the middle fossa. Once I remove this tumor, I will see the pituitary stalk. I will see the carotid artery, and I will see the hypothalamus probably. You see the pituitary stalk is seen behind it, behind the tumor. Here is the pituitary stalk, just here. And here is the hypothalamus.
Yes, beautiful.
I will show you how to retract the brain, how to expose the tumor of such huge epidermoid tumor has to be, and you realize the whole approach is supracerebellar. And you see my suction in my right hand, and I am breaking the tumor with my right hand. All vascular tumors, even AVMs, I like to hold suction in my right hand, which I use as retractor, as a tumor breaker in this case. As I told you, the most important and crucial nerve in this operation is the sixth. Maybe a little bit I go ahead. Now I will show you the opposite trigeminal. You will see the beauty. You can see, you see, I'm showing you this case because here, how the middle supracerebellar root has been expanded. Now you see here, of course, you cannot do such an exposure for a petroclipal meningioma, but it is possible. You see here, now this is the opposite carotid artery you can see here. That is the opposite optic nerve. Here. This is the opposite optic nerve. This is the pituitary stalk, and this is the hypothalamic area. Yeah. Then I come below to get in the CP angle. This is my third step. Third step is after the entire brain has relaxed, come in the CP angle by retrosigmoid root. Little bit I'll go further up.
Oh my goodness. 12:30 or 12, I guess. It's called golden quadrilateral.
See, we have done in my department more than 400 epidermoids or more, maybe more. You see, this is the basilar artery.
Go across.
So with that experience, I can say for sure, you see there is the sixth nerve you have seen below, and you will see both the six nerves. Basilar artery you will see very elaborately. Epidermoids are very beautiful tumor to remove. And I must tell you that if you have not removed it properly, if you have damaged any single perforator, you can kill the person. That is the basilar artery. You cannot just do anything. If you are having serious problem, you leave some tumor behind. There is no way you can say you can damage any structure. No structure can be damaged, because if you damage, it can have a very devastating clinical implication. This surgery I had done in front of 200 neurosurgeons who were watching me during better times here in Mumbai. It was done in a workshop, and we had more than 250 people in the audience who were watching this operation. You can hear my voice also, because I was talking to the people in the audience.
Yeah, I was wondering what that was.
Yeah. So this was a audience.
Yeah, it's coming from your feed.
So in the audience, people, there were.
No, it's okay. It's minor.
Yes.
What I'll do is, here is the stuff. Can you see?
I've never seen hypothalamus this beautifully before. That's fantastic.
You see the opposite carotid artery?
Yes.
Opposite chiasma. John, was there overriding of my voice with this? No.
No, it's just minor. It's a background noise from the tape, from the video, from the sound from the video.
Yeah.
Yeah. It's okay. You can tolerate it. It's minor.
You see the posterior communicating artery? And you see. So I will just skip this. You have to do a lot of irrigation during this operation, because by irrigation you can, remove some bits of the tumor. That's the end of the story, my dear.
That looks
So
beautiful.
I hope you enjoyed this video. And these epidermoid tumors are quite elaborate tumors. They run here, they run there, they run everywhere. So this is another tape which I don't want to show you now. This is another tumor wherein the tumor was entirely in the middle fossa. You see, this is an epidermoid tumor entirely in the middle fossa. And considering my experience with supracerebellar route, I removed this tumor completely by a supracerebellar route. So this was the first time in the literature a supracerebellar transtentorial route was adopted for a middle fossa tumor. So you can imagine how much comfortable I was with supracerebellar route that I adopted a supracerebellar route for this tumor. The last thing I want to show you is the brainstem. See, I will take another lecture on brainstem and what are the approaches to brainstem that I don't want to discuss too much here. But you can see the beauty of the anatomy that is shown in this picture. And this anatomy, I have a feeling that nobody in the world has ever been able to depict such beautiful anatomy of the brainstem. And that anatomy you can see in all its glory in this slide. This is another beautiful image showing the anatomy of the brainstem. And this I will give credit to Dr. Nunes from Argentina, who did this along with my colleagues in my own department, Dr. Sugdeeps in particular, who did this dissection. And I have a feeling that nobody in the world has ever been able to achieve such dissection of brainstem anatomy. So this we had published. And we had divided brainstem fibers into 3 types. One is short association fibers, one is association fibers, then small projection fibers and large projection fibers. And we had divided, which I will discuss in my subsequent lecture on brainstem anatomy and brainstem tumor surgery. But I want to just show you a few glimpses of this marvelous dissection of the brainstem. And what part of the brainstem is important, what is not important, is another chapter of World of Neurosurgery. This is the brainstem tumor, how to approach this tumor, what are the more safer areas of the brainstem, and these are all discussed. Now I want to show you, just before I leave you, this tumor in the brainstem, and there is a solid tumor here, anterior part of the brainstem. So I approach this tumor supracerebellar. Now you please see this here, that voice, unfortunately in the previous case, voice was duplicated. In this, it will not be. So this is the 4th nerve, which has supracerebellar surgical route. And then I will discuss with you the safe entry zone in the midbrain, which is not anterior to the midbrain, where there is corticospinal fibers. Now here I am cutting the tentorium. Then I work supracerebellar on the midbrain. So the tumors of the midbrain, tumors of the pons, tumors of the thalamus, amygdalohippocampectomy, Ugur Ture, we saw he was showing supracerebellar. That is midline. This is a lateral approach. I'm not talking of midline supracerebellar approach. I am talking of lateral supracerebellar surgical route. So you cut the tentorium, you have the whole midbrain in your picture, and then you have to identify the safe entry zone in the midbrain, which will be the next chapter of my study with you. So I have entered inside the brainstem now, midbrain. You see the supracerebellar root, how much my exposure is there. This is quite a large solid tumor. Inside the brainstem, inside the midbrain. You see, even thalamic tumors can be removed by this approach, but that you have to take more midline. I have never done amygdala hippocampectomy by this route. By a midline, of course. So this is the supracerebellar approach for brainstem tumor. So now just few sentences which I want to relate to younger people in the audience. Tumors which are difficult to remove are inherently more aggressive in their behavior. Recurrence in these cases is related to the aggressive nature of the tumor rather than incomplete resection. Very important sentence. Easier the tumor resection, well-defined, good arachnoid plane of dissection, more benign the nature of the tumor. Another beautiful sentence is, it's not the treatment, but the cellular behavior that will decide the recurrence of the tumor and outcome of the tumor. Recurrence of the tumor does not depend on radicality of or the extent of tumor resection. Very critical sentence. You see, you don't go for complete resection if there is any issue. If some nerve is in danger, some vessel is danger, don't remove that tumor, because recurrence does not depend on radicality of resection. That is a very important statement. So we must all remember that every neurosurgeon should have a plaque in front of his clinic stating that there are some patients whom we cannot help, there are none whom we cannot harm. If you are restrained in your approach, you are less likely to disturb me. For meningioma, these are the few last sentences. Resect the meningioma radically. Never go for incomplete resection. Second thing is, your approach should be such that the whole tumor should be removed in one approach. You can never say that I will remove half the tumor now and half the tumor later. That is not a good way of dealing with meningiomas. Patients should improve in symptoms. If symptomatic recurrence, then reoperate. And role of radiation for meningiomas is a little bit controversial and not proven. Avoid it if it is avoidable. So thank you, my dear friend. Thank you, Juha. Thank you, John. And thank you, dear friends. I'm sorry, John, that video was overlapping with the voice, which I didn't realize.
Oh, okay. It came out well. Juha, are you there?
Thank you very much, Atul. Excellent lecture again. Maybe you should say some words about the positioning of the patients.
Yeah,
Patient.
yeah,
I see that the patient is sitting. You forgot to say.
Yes. You were the one who really got that finest point in this operation is to do this operation supracerebellar. Sitting position makes the operation much more easier and much more possible. Your exposure in the middle fossa by sitting position becomes quite straightforward in your eye of vision. On the other hand, you can do it in lateral position and concord position and other positions, but that comfort level which sitting position gives you is not possible in my estimation. Like as even Ture mentioned the other day, that for large acoustic tumors, my approach is sitting position. See, sitting position is a beautiful surgical approach. And we have to, we cannot abandon that approach. Many stalwarts of neurosurgery like Yasser Gill, like Malice, like Sami, and all these people are very familiar and very, they use and they recommend sitting position. And I have a feeling that sitting position is very important if you are going to do supracerebellar surgical route like what I have shown. Of course, you can do in lateral position and park bench position. So that is the answer, Juha.
Okay, so for that, usually when you go abroad or you come to a new place, there is a big resistance against the sitting position by anesthetist. So you have to have good anesthetist, and actually this means that you have to have very good team to do that. But after some cases you have done, then they feel comfortable, but there is always extremely strong resistance against the sitting position. The air embolism is mentioned there, and so how are you doing? You don't have pictures of your position?
Picture of position I have not got, but they are sitting position where they are, the head is flexed, much more flexed than you do for acoustic tumor. Acoustic tumor, it is not so much flexed, it is turned. But for supracerebellar, it is flexed quite like for pineal region surgery. If you are doing pineal surgery, sitting position is the most beautiful position. And when you are doing sitting position for pineal tumor, you have to give quite a bit of flexion. So for supracerebellar route, you have to give quite a bit of flexion. And in that, you can access the tumor much better. You are.
Sure. This is the way I'm doing, yeah. So some other comments, questions from audience, please go ahead.
Congratulations, Dr. and friend Atul Goel. As always, excellent and amazing surgical procedures. It's not easy to fight, to resect these, especially GN tumors, because of the risk of vascular and also nerves lesion. So, congrats.
Thank you, Victor. Thank you. So nice of you. And Victor has been, Victor has been watching our symposium every time, and he is become, and I can see him happy wherever he sees my face, he becomes happy. So I'm very happy to see you, Victor, and I hope we can meet in person and we can share some happy moments together.
Thank you, Dr. Atul.
Any other question?
Dab, did you have a question? I'm sorry, maybe not. I'm sorry.
Renat, go ahead.
There is a question in the chat. John Bennett.
Okay.
Thank you, Professor Atul, for the great presentation, which is expected as always. Thank you.
Thank you. Thank you very much. Thank
Okay,
you.
we have a question, Dr. Atul, from Adnan Kasim. For complication prevention to sitting position, what modifications you have made to that approach to minimize embolism?
See, that is another chapter of how to prevent air embolism. And you have to have a very special anesthetist who can keep positive pressure ventilation. That is one thing. Second thing is you have to take care of every vein very meticulously. If any vein is bleeding, it is quite, you have to take care of it very quickly and very positively. If you make incision in the sigmoid sinus or transverse sinus, you have to take care very quickly. Petrosal, superior petrosal vein, if you take it early rather than breaking it and have bleeding, so you take it. So we have to be very positive about venous bleeding. But I can tell you, most of these things are worries which are not real worries. They should not really take you away from this fantastic surgical position. And in my operation theater, we have our anesthetists are very familiar with this surgical position. And if you are going to operate on the thalamus, if you are going to do amygdala hippocampectomy by supracerebellar route, if you are going to do pineal region surgery for supracerebellar route, You have to give sitting position. Pineal surgery in prone position can be possible. I'm not saying it is not possible, but it is quite difficult and quite cumbersome. Those who have not familiarized themselves for sitting position, they should see how others are doing. And if they are not, if their anesthetist is little bit hesitant, you make him, this anesthetist has to learn how to give anesthesia for a sitting position. You cannot say I will not use it, period, because my anesthetist is saying no. That is not a good answer to abandon such a fantastic surgical position.
Hey,
So,
So what I have been following, or my team has been following during the sitting position, is PCO2. If PCO2 is going down, then there is air embollism, and the anesthetist is compressing here, the neck, and then we see the leak and we seal it. So this is our practice. They are all the time following the PCO2 level, and if it
yes.
drops down, then there is air embolism.
See, there are
Of
many
course,
things.
always, if you have a Doppler running, then you have always sound, because small bubbles are always going, but that kind of clinical significance, this can be seen by PCO2 level. So if it drops down, then you should be very fast, like Atul said, very fast, seal the REM.
Another very important thing is Juha. If you are a slow surgeon, if your surgery is going to be slow, no, I know, of course, you are not. You are one of the fastest neurosurgeons I have seen, and we all know you. But if somebody is a slow surgeon, if somebody is going to take acoustic tumor surgery for 10 hours or 8 hours or 8 hours, then sitting position is not a good operation for him. Then you do lateral and all. Because, if you are, because your hands will get tired, you cannot lift up your hands like that. And this is quite a tiring position for the patient and for the surgeon. So you have to be quick surgeon. And I have, I sometimes mention, which is not a good thing to mention in a neurosurgical parlance, that none of your operations should take more than 1 hour, except glomus jugular tumor, bypass surgery, and sometimes one more surgery I used to say. So 2 or 3 or 4 operation. Otherwise, 1 hour, 1.5 hours is the ultimate limit for any kind of operation. If you have that power, if you can say, yes, I can do within that time limit, then sitting position is a good operation. If you are saying I will do acoustic tumor or petroclipal meningioma for 10 hours in sitting position, patient will not wake up only, because during that 10 hours, he will certainly get several issues. So you have to be quick. If you have to do this sitting position, and if you have to do supracerebellar route, you have to be a fast surgeon. That is another very important, you have to learn the art of breaking the tumor. You have to learn the art of demolishing the tumor. You have to know when to not to coagulate. You have to know what to coagulate, because petroclipal tumors, if you coagulate any small perforator, there is a possibility of death. If you coagulate one perforator, the patient may never wake up. If you damage the sixth nerve, he will have very devastating sixth nerve deficit, which is possible. I am not saying this is not possible and I don't have. I also have, and I have several occasions where sixth nerve is damaged, where seventh nerve is damaged, where the hemiplegia occurs. I have complications, all right. And these complications are a part and parcel of our neurosurgical life. If we have become a neurosurgeon, we have to tolerate, we have to love and enjoy our success, and we have to learn and accept our problems and our complications, which will happen in our life. So if there is a complication, you cannot say, there are possibilities, but the patient will suffer throughout the life. So we have to be very, very, neurosurgery is a great subject, but neurosurgery is a philosophical subject. You have to know when to stop. You have to know when not to damage anything. but they can be damaged. So we have to be prepared, and patient has to be prepared that these are dangerous operations. But if you give beautiful surgery, you give new life. And you give new life. Many of these tumors are completely benign tumors. Many of these tumors, you remove, the patient lives all his life without any problem. So it is depends on how much training you have. As Juha says, your training, the number of operations, the number of hours you spend in the operation theater, the number of tumors, the number of vascular problems you have, the way you have to handle the bleeding, the way you have to, when bleeding occurs, don't start jumping. You see, bleeding will occur in our neurosurgical life. It can never happen that there is a bloodless operation. So when bleeding occurs, which vessel to coagulate, how to coagulate, which vessel to will stop on its own, which vessel should not be coagulated, where we should use Surgicel, where we should use gel foam, where we should do just little bit pressure, where we should just ignore. So there are various ways of handling bleeding, and how we handle bleeding is the way we are, if we are a good surgeon or a bad surgeon or a slow surgeon, is how we handle blood. When blood occurs, we should not start shouting and all those things. We should be very, particularly in things like AVM surgery. AVM surgery is going to bleed. And if it bleeds, and if you are, if you are not able to handle, you coagulate, burn, means that will be the end of the story. So you have to know how to deal with blood. And that dealing with blood will come by the number of operations you are doing, the number of hours you have spent in the operation theater, the number of tumors you have operated. So that is that is the only way to learn how to do a quick operation, how to do a sophisticated operation, make simple. So that is on you. And that has to be learned, and that has to be developed, and that has to be relayed to the patient, the benefit of that training. So that is the thing.
Okay, Dr. Goel, Jorge Salazar, a neurosurgeon from Mexico City, has a question. Go ahead, Jorge.
Hello, John. Can you hear me?
Yes.
Yes, on the first place, I would like to congratulate Dr. Atul Goel and Professor Juha also for staging this magnificent program. During this lecture, we have seen beautiful surgical approaches. We have many residents and young neurosurgeons are watching this program. And I would like to, Professor Atul, if you can summarize the best indications for those two surgical approaches. When do you decide to go by the middle fossa, and when do you decide to do a cerebellar translatorial approach? Thank you.
Yeah, that is a very important question, and that is what I tried to answer in my lecture. You see, that is what I tried to answer by showing several images where the larger tumor is in the middle fossa, you take middle fossa approach. Where the tumor vascularity comes from the middle fossa, you take middle fossa approach. When the tumor is larger portion is in the posterior cranial fossa, supracerebellar approach is a beautiful approach. So petroclipal meningiomas by definition are those which arise medial to the trigeminal nerve. So some tumors go in the cavernous sinus. That is not a petroclipal. Petroclipal are those which arise medial to the trigeminal nerve. Those are petroclipal meningiomas. So for typical petroclipal meningioma, supracerebellar approach is a beautiful approach. But tumors which extend in the middle fossa, in the cavernous sinus, and all, then of course we will have to do an extensive, we can select some cases by supracerebellar, but in many of these cases where the cavernous sinus involvement is much more than possible, then we have to do middle fossa approach. Middle fossa approach is a beautiful approach. Middle fossa approach is a lifeline approach for all skull-based surgeons of the world. Supracerebellar approach is an evolving operation. supracerebellar approach is a very fantastic and useful operation. And my recommendation is that we must not ignore this beautiful approach for many of these tumors, because it makes the life so much easier and simpler. So we have to learn this approach. That is my answer to your question.
Thank you.
Takashi, any question from you?
In Japan, very few neurosurgeons can do supracerebellar approach because air embolism complication is very, we are told, and we are very afraid of that kind of complications. To avoid air embolism, this kind of thorough anesthesia and monitoring is important, but we are hurt, so we have no experience of such approach. But some doctors, a few doctors can do it, but in Japan it's not familiar, so we have to learn this beautiful approach. Beautiful operative field is very beautiful, very wide.
You can actually, Takashi, you can use a park bench or lateral position also.
Park bench, yes. Usually we perform prone position, but yeah, park bench or lateral position is also useful, but very difficult to get an operative field, enough operative field.
That's right. I agree with you. It is difficult to get such wide operative field, and you are not comfortable. You have to keep on bending and all those things. So that is why, if you are not familiar with this position, then of course you have to do very elaborate middle fossa approach and petrous bone drilling and facial nerve mobilization. And I mentioned that I used to do all my cases by middle fossa. But as we described this supracerebellar route, we identified that this is a very fantastic approach. There is no question about it. And now many people in the world are doing this approach. Many people, many senior people in the world are adopting supracerebellar approach for petroclipal meningiomas.
Yeah, I understand. I want to learn. And after COVID-19 year, we have to visit your institute and learn and more.
Of course.
Atul, you mentioned that you get tired when operating on sitting position. So my student Johan Shoku, he made his PhD on pineal tumors, and one of the developments or outcomes of this thesis was that we developed the sitting position. So the patient is actually not sitting but praying forward. So you have the back of the patient. You can put your hands on the back of the patient. You never get tired with that. It's very good. And a second thing when doing surgery is the mouth switch of Yasaki. So it is beautiful when you can turn the microscope very quickly with using the mouth switch, so you can do very fast surgery. You were speaking about fast surgery. If you want to make even faster, then you take the mouth switch in use. You can reduce the time 30–40% with that. Very few neurosurgeons in the world are using the mouth switch. It's my estimate that around 5%, but this is one of the things you should take in use. Now, of course, there are now the use of exoscope is proposed. What I read, that those who are using mouth switch should not take exoscope in use because they cannot so easily learn, and other surgeons. Just sudden thoughts came in my mind. Thank you.
So, John?
Yes, okay, very good, Atul. And I thank you, and I'm sure all the residents listening to you appreciate you taking the time.
I was just wondering, John, that video, my voice, doubling of my voice was not a disturbance, or was it?
No, it was minor. It was very minor.
Yeah.
Minor. We've come to expect that sometimes with videos. Anyway, Dr. Liao, any results from the Chinese neurosurgical community? Are you there, Dr. Liao?
Yeah, I'm here. And actually, tonight we have more than 1,000 audience. It's
Oh, great.
around 1,300 audience.
And
It's
thank you for
very
the
informative
translation.
lecture.
Oh.
It takes time for me to digest the lecture. Thank you very much, Professor Goel.
Yeah, translate and digest at the same time. And thank you, Takashi, for translating to Japan. And Juha, any plans for next week yet? Or are we still?
I have asked Dr. Luis Borba from Brazil will speak next week.
Okay, great.
Yeah, this is yeah.
Very good. Okay, well, thank you everybody for participating, especially Dr. Goel and Juha, and we'll see you next week.
Thank you very
Next week,
much,
see you next week.
everybody.
Thank you.
Good night.
Informative.
Have a good day.